Hello guys, welcome you all for the today's session. So today we are dealing with the FMGE Spotlight. I'm Dr. 𝐒𝐿𝐻𝐿𝐻𝐿, your orthopedic faculty at PW MedEd. So today I've come up with a strategy to say, so usually we do this MCQs, right, for the rapid revision series or something like that. But today what I've planned is I have come with a bunch or a long list of one-liners, right? So we will do a quick revision of every aspect, like I'll touch every smaller topic of orthopedics, but very quickly because we have only limited time. So let's get started early. So first I would deal with the most important question. Usually it is seen in every exam, that is about nerve injuries. So usually they will ask in the MCQ type, but I have not given any question type this time. So let us solve this. So here I will tell you what is the question is. So this is an X-ray which is given in your exam, and they're going to ask you about the nerve injury associated with this particular fracture. So if you see this fracture is nothing but the humerus fracture, right? You can see there is a humerus fracture here, and in this humerus fracture you see that the fracture is at the level of the distal, that is the junction of the middle and the distal 1/3, right? So usually we divide this into proximal, middle and the distal 1/3, right? So whenever you see a fracture of the humerus, especially at the level of this middle and the distal junction of the middle and the distal third, you have to be careful because there is a nerve which is passing towards this small area which is tethered to the bone, right? So whenever there is a fracture, there is a probability of this nerve getting injured, and this particular nerve is nothing but the very important radial nerve. So this important radial nerve will get damaged here, and this is called nothing but your Holstein-Lewis fracture. So this is called the Holstein-Lewis fracture. So here the injury or whatever you have to check for the radial nerve. Then how do you do that? The checking of the radial nerve is by seeing whether the wrist is stable. Otherwise it will result in what is called as the wrist drop. So whenever there is a radial nerve damage, it will result in wrist drop. So when you encounter such fractures in the casualty, so you have to check for the X-ray, and when you see these fractures, you have to always check for the radial nerve. So how do you check for the radial nerve? Radial nerve, what does it do? It supplies the extensors. So you will check for the wrist extension. And first you can always start with your finger extension, but here the damage to pin is not very much there. The probability of radial nerve is very high, hence you will directly check for wrist extension, then your elbow extension, right? So this is about the radial nerve, and what you have to remember is this is mostly encountered during the fracture of the humerus, especially in this particular area, right? So similarly these are the other X-rays which can be asked, the potential questions here. So whenever there is a proximal humerus fracture, so this is the fracture of the proximal humerus. So this is the fracture of the proximal humerus. So here which nerve you have to be careful about? You have to be careful about your axillary nerve, right? So here the axillary nerve is the one which is at the danger. And what does this axillary nerve do? It supplies which particular muscle? So it supplies the deltoid muscle in particular. So what is this deltoid muscle doing? This deltoid muscle is essential for the abduction of the shoulder. So here you will check for the abduction of the shoulder. So usually in the fractures we don't do this test checking for the abduction, but what we can do is we can check for the sensory component of this axillary nerve, and this is nothing but your regimental badge area. So regimental badge area is nothing but that particular area where you can check that the BCG vaccination is given to the infants, right? So that particular area, this area above where the army officers will put the badge, so this is called the regimental badge area, and this particular area gets numb. So there is only a patch of area which gets numb, and you can test it as a sensory component of the axillary nerve. So where do you usually check this? You check this in the proximal humerus fractures. And now coming to the next one. So what is this? This is your very easy, right? Anterior dislocation of shoulder. So this is the anterior dislocation of the shoulder. Again, which nerve is at damaged? Which nerve is at risk? again your axillary nerve. Axillary nerve is one more important area where you have to again check for axillary nerve, that is your anterior dislocation of the shoulder. So both the proximal humerus, especially the surgical neck of the humerus, and then your anterior dislocation, both have this potential of damaging your axillary nerve. And now next one, what is this? So this is about the hip. This is your posterior dislocation of the hips, right? The posterior dislocation of the hip. So whenever you encounter this posterior dislocation of the hip, for which nerve you have to be checking for? You will check for the important nerve, that is your sciatic nerve. So here you will check for this important nerve, that is your sciatic nerve. So this nerve can get damaged during your posterior dislocation of the hip, right? Next, now next one. So this is very important image. This been asked in your recent INICT exam. So this is a very important image. Please concentrate. So here what is happening here, you can see there are two nerves which is there. So this, name them. This is the tibial nerve and this is the common peroneal nerve. So CPN is your common peroneal nerve, right? So when does this get damaged? So you can clearly see here, it is during the fracture of neck of the fibula. So whenever there is a fracture of the neck of the fibula, this gets damaged. So this is the common peroneal nerve which is getting damaged during your during the fracture neck of the fibula, especially during the extensive trauma injuries. Like it can be a polytrauma also, because the violence which has been created will cause the damage to this neck of the fibula, which will result in the damage of this common peroneal nerve. So whenever there is a common peroneal nerve damage, this will result in what? This will result in what is called as the foot drop. So the foot drop, and the patient comes with the high stepping gait, right? If he is able to walk after the union of the fibula, you will see that the patient walks with the high stepping gait. This is because there is a damage to the CPN, that is the common peroneal nerve, which is most commonly encountered during the fibula fractures, right? So this is about your nerve injuries, especially as the complication of the fracture. So whenever there is a fracture, there could be certain complications such as your nerve injuries, your vascular injuries, right? But sometimes these nerve injuries can also be seen in certain syndromes which are called as the entrapment syndrome. That is, these nerves being crushed at certain areas of the body, and similarly they will produce all the symptoms like the wrist drop again and various other symptoms specific for each nerve, right? So here what do we, let us go into quick revision of those entrapment syndromes. The most favorite of everybody, every examiner, is the carpal tunnel syndrome. So what is this carpal tunnel syndrome? The carpal tunnel syndrome is the where the carpal tunnel, the carpal tunnel area at the wrist joint. Now here there is an important nerve which gets damaged, which is called as the median nerve. So this is the median nerve which is getting damaged at the carpal tunnel. So during this carpal tunnel syndrome, the patient presents with the symptoms of the median nerve injury, right? So they will produce the sensations which are present around the 3.5 fingers, and there is a muscular atrophy of the thenar muscles, right? So this is mostly present at the night, and there are two important tests which you have to remember is the Durkan's test. So direct compression, the Durkan's test, which is there with direct compression of the carpal tunnel, will produce the symptoms. So this is very important, again recently asked in the exam, right? So Durkan's test is one, and what is the nerve which is getting involved in the carpal tunnel is the median nerve. Similarly, we have one more canal which is called as the Ghayens canal, and here you see there is the entrapment of this ulnar nerve. So whenever there is this ulnar nerve damage, the patient present with the tingling and numbness of the medial 1.5 fingers. So medial 1.5 is the one area of the ulnar nerve. So now this Ghayens canal syndrome will result in the symptoms of the ulnar nerve palsy, such as your claw hand, your tingling, numbness, and various other tests which we'll subsequently discuss. So for now, let's remember that the Ghayens canal will result in the ulnar nerve palsy, right? Next comes the piriformis syndrome. So piriformis is the fossa from where an important nerve which is called as the sciatic nerve which is getting involved there. So this is the piriformis syndrome. There the sciatic nerve is involved, right? And then we have the pronator syndrome. Pronator syndrome is the pronator teres where the median nerve passes between the two heads of the pronator teres, and now there is a high chances of this median nerve getting crushed again. So this might result in the again symptoms producing along the thenar muscles. Next, the cubital tunnel. Cubital tunnel is for the ulnar nerve. So cubital tunnel is the ulnar nerve which gets damaged. So here the ulnar nerve will present the symptoms such as your 1.5 involvement of the 1.5 fingers, then various other tests which has been involved, right? And then comes the tarsal tunnel. So tarsal tunnel, you will have the posterior tibial nerve which is damaged. So the posterior tibial nerve which is damaged in the tarsal tunnel, right? Then we have the meralgia paresthetica and chiralgia paresthetica. So these two again are very important. In meralgia paresthetica, we'll see the lateral cutaneous nerve of the thigh, and in the chiralgia you will see the superficial radial nerve which has been involved, the superficial radial nerve. And so this you have to remember, the meralgia paresthetica and the chiralgia paresthetica. In meralgia paresthetica, you will see the lateral cutaneous nerve of the thigh which is involved. And what are the symptoms which the patient presents with? The patient presents with there is a specific tingling and numbness sensation over the lateral aspect of the thigh. And this is very, 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 very sensitive. Like even in case of female patients, even the cloth which touches the lateral aspect will produce symptoms, and the patient will tell you the symptoms of that tingling and numbness, even the touch of the cloth over the lateral aspect. So that is about the meralgia paresthetica. Similarly, the superficial radial nerve, this area of the superficial radial nerve gets numb. This is called chiralgia paresthetica. So these are the various nerve and their entrapment syndromes. Previously, we have discussed various fractures and dislocations and the involvement of the nerves. So these are all potential questions for your upcoming exam, right? Okay, now as I've told you that there are 3 important nerves which you have to understand, and there are few important tests which you have to remember, right? So this is about the radial nerve, the ulnar nerve, and the median nerve. Right, so here what happens is the radial nerve, there are no much tests to remember. Only you have to remember are the extensors which gets involved, and the branch of the radial nerve which is the posterior interosseous nerve might result in the finger drop, right? Only this is what is important. So extension, that is which is resulting in loss of extension which causes the wrist drop, and if the finger, only single finger is involved, which is because of the involvement of the posterior interosseous nerve, which will result in the finger drop, right? And now what you have to remember is the very, very good example of the radial nerve is Saturday nerve palsy. Saturday nerve palsy. What is the Saturday nerve palsy? This is a classical example of neuropraxia. So in this case of neuropraxia, what happens is, so usually during the Saturday nights, the people who, they booze during the Saturday nights and they fall in a chair with certain positions, which causes damage to this radial nerve. But that is this damage is neuropraxia, right? So neuropraxia is nothing but there is no internal damage to the nerve, only the nerve is like sulking, right? The nerve, there is only the axonal block which is present there, and over a period of time this axonal block will return back and will result in complete recovery. That is, there will be a 100% recovery in case of neuropraxia. This much you have to remember. So whenever there is a Saturday nerve palsy, you have to remember that is because of the radial nerve damage, and the recovery is 100%. And here what you see is the patient presents with the sudden wrist drop. They present with sudden wrist drop. So that is about the radial nerve which you have to remember. Next comes the ulnar nerve. So ulnar nerve is very, very important. This is called as the musician's nerve. So you all know the musician's nerve, which is very, very important. Okay, KP Chowdhury we will talk about the cubitus varus. Again, during the deformities, I will teach you about the cubitus varus. For now, let us understand the ulnar nerve and its importance, right? So the ulnar nerve is called the musician's nerve because it is mainly involved in doing the fine movements, right? In doing the fine movements of the hand. So what are all the muscles which are involved here? Not going into great detail. What you have to remember is the medial 1.5 fingers, that is the middle and the little finger is involved in case of the ulnar nerve, which results in what deformity? This is called the claw hand. So you will see the clawing of the hand. So this is your ulnar nerve palsy, where you see the atrophy of the hypothenar muscles, and most importantly, they will supply the pad and the dab. So these are the muscles, the palmar interossei and the dorsal interossei, right? So palmar interossei and dorsal interossei, there is the abduction and adduction, which is tested by the CART test and the 𝐒𝐿 test. So you have to remember that there are two important tests for the ulnar nerve, the CART test and the 𝐒𝐿 test. So CART test will test the adduction, the 𝐒𝐿 will test your abduction, right? So CART test for the adduction and this is for your abduction. And what is the one more thing which you have to remember? Yes, very good. That is the Fromen's sign. Which is the book test, right? So book test Fromen's sign, which is mainly for the adduction of the thumb. So with the adduction of the thumb, where we hold the book, right? And if we are not able to hold the book with adduction, we will use this flexor is applied by your median nerve. So whenever somebody is flexing the thumb and holding the book, that is the Fromen's signs positive. That means the Fromen's signs positive, which indicates that there is the ulnar nerve palsy which is present, right? That is about the ulnar nerve. Now come to the median nerve. So median nerve, again, it supplies all the thenar muscles and the flexors, the main flexors of the hand, right? So the main flexors and the thenar muscles are supplied by the median nerve, and the tests which are involved here is the pen test. So the pen test, so usually we do the holding of the pen. So pen is put in right in front of the palm and the patient is asked to touch the pen. So this is the pen test which is used for the median nerve. So where there are various other tests which are there, that is the pointing index, right? So pointing index is again the lack of flexors of the long flexors of the hand. So whenever there is a median nerve palsy, this complete finger will be unable, the index finger completely will be unable to get flexed. So hence you will see this as the pointing index. Hence you can call this as the Benedict sign. And there is also the ape thumb deformity. So usually the thumb is perpendicular to the palm, but in apes other than the human, you will see the thumb is in line with the hand. So this is called the ape thumb deformity, which is again a sign of your median nerve. So ape thumb deformity, the Benedict sign, pointing index, and one more important sign is the 𝐒𝐿 sign, which is called as the O sign. Again, it is specific for one important, that is the anterior interosseous nerve. So whenever you want to talk about the branch of the median nerve, that is the anterior interosseous nerve, this is called the 𝐒𝐿 sign, the OK sign, or the O sign. So the perfect O should be visible, and whenever there is a perfect O, that means it is the anterior interosseous nerve is perfect. So if the O is not round like this, then this indicates the AIN nerve palsy. So this is the AN nerve palsy. So this is about the important test which you have to remember regarding the nerve injuries, especially the radial nerve, the ulnar nerve, and the median nerve, right? So this is very, very important, and keep revising all the tests. And now, so this could, and till now we have understood the test, and sometimes they might ask the classification of the nerve injury. There are two classifications. One is the Sedan's classification, and then you have your Sunderland's classification. But whatever might be the classification, what you have to remember is there are three important terms which you have to remember, as I've already explained. There are neuropraxia, there is axonotemesis, and there is neurotemesis, right? So here what happens is whenever there is neuropraxia, there will be 100% recovery. That means no internal damage will happen to the nerve. Then axonotemesis is there is damage to the axon according to the Sedan's classification. And neurotemesis is cut of the nerve. So here what happens is the entire nerve is cut, hence the recovery is not seen. So there is no recovery. And here the recovery is 100%. So this is the brief which you have to remember. The Sedan's is 3, that is neuropraxia, axon, and neurotemesis. The Sunderland's is now 5 classifications where it has been elaborated. But what is important for you is here neuropraxia, there is 100% recovery. For example, is a Saturday nerve palsy where the radial nerve is involved, and neurotemesis is the transection of the nerve. So complete transection of the nerve where you require tendon transfers to completely recover the function of the hand, right? Okay, now that is about the nerve injuries. Now let us deal about the various fractures here, various fracture patterns and uh, their names, which is sometimes very important. And this would at least there would be some or other question from this topic, right? So here, if you see, there are various names which are given to the fracture types. For example, there is Monteggia and Galeazzi. So Monteggia and Galeazzi is nothing but the forearm fractures, and what happens is in one Monteggia is the ulnar fracture. So there will be fracture of ulnar with the proximal radio-ulnar joint involvement, that is the radial head dislocation or radial head fracture. So that is Monteggia. What is Galeazzi? Galeazzi is nothing but your radius fracture. So radius fracture with the distal radio-ulnar joint involvement. So this two you have to remember, the Monteggia and the Galeazzi. Next comes the spine. So spine fractures, there are three important fractures which you have to remember. Jefferson's fracture for C1 vertebrae. So Jefferson is for C1 vertebrae. So Jefferson's fracture is, if you remember this, F is for first. So C1 is Jefferson's, that is the ring fracture. So bilateral ring fracture of the atlas which has been damaged, which has been fractured. This is called C1 vertebra. Next is Hangman's. Hangman's is C2, that is nothing but traumatic spondylolisthesis of C2, right? Traumatic spondylolisthesis of C2, right? So here you have to remember that Jefferson is C1, Hangman's is C2, and what is 𝐒𝐄𝐝? 𝐒𝐄𝐝 is usually the lower cervical vertebrae which are involved, but usually it is C6 or C7 spinous process which is damaged. Only the spinous process part which is damaged, the 𝐒𝐄𝐝's fracture. This is called the 𝐒𝐄𝐝's fracture, right? And then comes the fractures of the upper limb. So most important fractures of the upper limb which you have to remember, starting off with the hand, especially this is for thumb. So these two you have to remember, that is Bennett's and Rolando. So Bennett's and Rolando, if you see B is bi. So Bennett's is bi. There is only two-part fracture which happens at the base of the thumb. At the base of the thumb is the two-part fracture which occurs. And what is Rolando? Rolando is comminuted fracture. Rolando is the comminuted fracture of the base of the thumb or the metacarpal, right? So base of the thumb or the metacarpal. You have to remember these two. There are two important fractures which you have to remember, the Bennett's and the Rolando. Bennett's is bi, B for B, which is a two-part fracture. It has to be fixed properly. So here the surgical intervention is important. Surgery is important for the proper functioning because of the pull of the tendon. There is a tendon which is attached to the larger part and it pulls back the fragment. Hence Bennett's require appropriate reduction. Please remember both are intra-articular fractures, but Bennett's is a vertical fracture and Rolando is a comminuted fracture. So it is three part, right? Then very important, Colles fracture, Smith fracture and Schoffer's fracture. When it comes to the Colles fracture, it is the distal radius fracture. So this is the distal radius fracture, and Smith is also a distal radius fracture. So what is the difference between the two? So coming to the Colles fracture, the displacement of that particular fracture will decide whether it is a Colles fracture or a Smith's fracture. If the distal radius fracture is going into a dorsal displacement, so for everybody this is the dorsal and this is the ventral, right? The palmar is the ventral, this is the dorsal aspect. If there is a fracture and if the fracture is tilting or displaced towards the dorsal aspect, it is called the Colles fracture. This is the most common fracture which we encountered in patients of elderly women, especially the osteoporotic women, right? Menopausal, postmenopausal osteoporotic women, usually we see this type of fracture which is called as the Colles fracture, right? And then the Smith's fracture is exactly opposite to the distal fracture, where you see the displacement is ventral, right? But please remember both of these are extra-articular fractures. These are the extra-articular fractures, very important. Extra-articular fractures occurring at the metaphyseal junction And with the based upon the displacement, you will decide whether it is Colles fracture or the Smith's fracture. Now coming to Schoffer's fracture. Schoffer's fracture is nothing but your isolated radial styloid fracture. This has been observed in the chauffeurs while they are parking the cars because of the placement of their wrist and during the driving process, hence it is named as the Schoffer's fracture. What you have to remember, it is the isolated radial styloid process fracture, right? That is about the Schoffer's fracture. Now coming to some more things. So as I've told you that there is a Colles fracture, there is a Smith's fracture which is extra-articular. Now comes the intra-articular fracture of the distal radius. So Barton's fracture is intra-articular fracture which can again be a dorsal displacement or a ventral displacement. That means the Barton's can be a dorsal Barton's or a ventral Barton's. When it extends into the joint, it is intra-articular. It is called as the Barton's fracture, similarly seen in the distal radius. So that is about the upper limb. Now coming to the pelvis. So this is about the pelvis here. So pelvis, you see there are two important fractures, right? So there is a straddle fracture, there is a jumper's fracture. The straddle fracture is nothing but it is a bilateral fracture of both superior and the inferior pubic rami. Superior and the inferior pubic rami. Right, so it is bilateral, both superior and inferior pubic rami. This is nothing but your straddle fracture in case of pelvis. Then what is jumper's fracture? Jumper's fracture or suicidal fracture is nothing but fracture of the sacrum. There is a fracture of the sacrum which is called as the jumper's fracture. Then what is runners, Maisonneuve's, cotton, Potts? This is all about your tibia and fibula. So tibia and fibula. So now what is a runner's fracture? So runner's fracture is nothing but the fracture which you see in fibula, which is somewhere around 3 to 8 centimeters. 3 to 8 centimeters above the lateral malleolus. So I will just finish off all the fractures and then I will try to show you some images so that you can identify it by yourself, right? So first let us complete the table and then I will show you a few images, right? That answers KP Chowdhury's question, okay? So now we are dealing with the runner's fracture. The runner's fracture is the fibular fracture which is seen somewhere around 3 to 5 or 8 centimeters above the lateral malleolus, which is called as runner's fracture. And important thing is the Maisonneuve's fracture. What is Maisonneuve's fracture? Maisonneuve's fracture is that important fracture which is where you see an ankle fracture associated with the fracture neck of fibula, right? So usually we have this habit of taking x-rays wherever the patient complains of pain. So here for an example, if the patient has come with a pain in ankle, you have seen there is a tenderness, there is some deformity in the ankle and you have identified it as an ankle fracture. But please remember the golden rule in orthopedics is always to examine one joint above and one joint below. So here comes the case of Maisonneuve's fracture where the impact of the ankle joint, that is the damage to the lateral malleolus of the fibula, is extended up to the proximal joint, that is the neck of the fibula, also gets fractured, and this will result in the potential damage to the fibular nerve, that is the common peroneal nerve. So this fracture which is seen both in the ankle and in the upper part of the fibula, the lower part and the upper part of the fibula is involved. This is called as the Maisonneuve's fracture. Now very easy, the Cottons and the Potts. So you will remember this as Cottons is bimalleolar fracture, Cottons is trimalleolar fracture. So Potts is bimalleolar fracture when there are malleolar fracture, that is the medial malleolus and the lateral malleolus of the ankle, right? And then the Cottons is trimalleolar whenever there is an important or whenever there is involvement of the posterior malleolus. So if you remember the ankle as the medial malleolus, the lateral malleolus and the posterior malleolus, right? So this trimalleolar is nothing but Cotton, the bimalleolar is nothing but Potts. Now coming to the metatarsals. So metatarsals, there are two important fractures which you have to remember. One is the March fracture, the second one is the Jones fracture. So when is the March fracture? March fracture is nothing but this is the stress fracture which is seen in the second metatarsal. This is seen in the second metatarsal. What do I mean by a stress fracture? What do I mean by the stress fracture? The stress fracture is nothing but a repetitive stress which is given to a normal bone. So here you have to remember that the bone is normal, but there is lot amount of the repetitive stress which is given to this bone, which will result in fracture, which is the March fracture in case of the second metatarsal. Then what is a pathological fracture? Pathological fracture is the fracture which is occurring with the trivial trauma in case of an abnormal bone. Fine. So that is bone itself is abnormal. For example, in case of tumors, right? In case of metabolic disorders, like for example, if the patient is having rickets and then there is a fracture which is present there, that is a pathological fracture. If the patient is suffering from osteogenesis imperfecta and then presents you with the fracture. So as the bone is already abnormal and even the smallest amount of stress which is causing on it will result in damage to that particular bone, hence that is called as the pathological fracture. But what is stress fracture? Stress fracture is the repetitive stress which is occurring in a normal bone, right? For example, in case of soldiers, like they completely march causing stress over the second metatarsal, which is nothing but your March fracture. Then what is a Jones fracture? Jones fracture is fifth metatarsal, and specifically the base of the fifth metatarsal which is damaged, which is called as the Jones fracture. What is so special about it? Again, it is divided into 3 zones and it is a very special area which is called the watershed area. That means the supply of the blood is from proximal and the distal. There is a gap in which every potential of non-healing can occur. So whenever you encounter a Jones fracture, you should be much careful in treatment of it. Hence, there is a specific name given to it, the Jones fracture, the base of the fifth metatarsal. Similarly, the neck of the fifth metacarpal is called as the Boxer's fracture. Similarly, the fifth metacarpal neck is called the Boxer's fracture. And finally, what is aviator's fracture? Aviator's fracture is nothing but your talus fracture. Talus fracture is the aviator's fracture, right? So this is about the various fractures and their names, which are very, very important. So they can just ask what is this type of fracture, or they can just show you the image and then they can ask you, or they can ask you as a bit, right? So these are the various fractures, and now it is time for you to identify these images and quickly name them so that we can have a quick revision of all the fractures again. So if you see this image, the first one, you can see that there is a extra articular so this is the extra articular fracture here, which you can see, which is not extending into the joint, but obviously there is a displacement. So here what I'm talking about is the dorsal tilt or dorsal displacement. Hence this is your 𝐒𝐂𝐈𝐻 fracture. So this is your 𝐒𝐂𝐈𝐻 fracture, which is seen in the distal radius, which is an extra articular. There is no involvement of the joint and there is a tilt. There is a displacement towards the dorsal aspect. So this is your dorsal, and hence this is nothing but your 𝐒𝐂𝐈𝐻 fracture, right? So whenever there is a ventral, similarly if there is a ventral tilt or the ventral displacement in case of again a distal radius, so this is your Smith fracture. So this is your Smith fracture. So that is your 𝐒𝐂𝐈𝐻 fracture and this is your Smith fracture. This is how you differentiate it in our exam. You have to always take the lateral view. So lateral view is the one which will tell you about the tilt of the dorsal and the ventral displacement or the tilt. So this is how you differentiate between the 𝐒𝐂𝐈𝐻 fracture and the Smith fracture. Now can somebody just identify what is this fracture? So we are dealing with the foot, the metacarpals, and here if you see there is a fracture of the fifth metacarpal. So this is nothing but your Jones fracture. So this is nothing but your Jones fracture. So base of the fifth metacarpal is your Jones fracture, right? And then coming on to the next x-ray. So this is again a fracture of the hand. We have already dealt with it. So this is the fracture of the hand where you can see there are 2 important x-rays, and this is your Bennett's, right? So this is your Bennett's fracture. And this is your Rolando fracture, which is a comminuted fracture, which is a 3-part fracture. Both are intra-articular, right? But this Rolando is a comminuted, and here Bennett's is 2-part. Now remember, B for bi is 2, right? So this is a Bennett's fracture. And what did I tell about Bennett's? Is this is a tendon which is attached here and it keeps pulling this fragment downwards. So to avoid this pulling of the tendon, you need for accurate reduction of the particular fragment. So this fracture has to be reduced and maintained to maintain this joint line. So this joint line has to be maintained, right? So that the reduction should be so accurate, so but that the joint line is maintained. This is anyhow communicated, so you don't aim for accurate reduction, right? So this is how you treat for the Bennett's, and this is how you need to differentiate between Bennett's and the Rolando fracture, right? So that is about the fracture of the hand, Bennett's and the Rolando. Now can you name them? Can you name all these? So what are we dealing with? The first one, I want everybody to answer quickly the first one. So this is your A, this is your B, and this is your C. So if you followed the table, you will answer it quickly. So what is A, B, and C? So here A, if you see, there is a fracture of the radius with the distal radio-ulnar joint. So this is the fracture of the radius. So this is the fracture of the radius with DRUJ. So whenever there is fracture of the radius with distal radio-ulnar joint, this is nothing but your 𝐒𝐿𝐄𝐝 fracture. So this is nothing but your 𝐒𝐿𝐄𝐝 fracture, right? And what is B? B is fracture of the ulna. Here you see there is a fracture of the ulna, and then you can see the radial head is involved. So PRUJ, the proximal radio-ulnar joint involvement. This is the very classical Monteggia fracture. So this is very classical, the Monteggia fracture, right? So this is the Monteggia fracture. And C is very, very important, very, very important. So if you see, there is the displacement in the ankle, and similarly you can see there is a problem in the fibular neck. So this is what I was telling you about the Mason-Nevis fracture. So this is nothing but your Mason-Nevis fracture, where you see that there is the ankle fracture which is present and which has been impacted above, that is by your fibular neck fracture. So here there is again a potential injury for your common peroneal nerve. So this is the Mason-Nevis fracture. So these are certain examples which I have given. So this can be asked in the image form, or they can be asked as the MCQ form. So now what is this? So this here you can identify if there is a fracture bilateral, superior pubic, inferior pubic. So this is the straddle fracture. So this is the straddle fracture of the pelvis, where both the inferior and superior pubic rami on both sides are damaged. So this is the example of the straddle fracture, right? So that completes the fractures. And once we are done with the naming of the fractures, you have to know how to treat them. So how do you treat them? You treat them based upon the classification, based upon whether it is a simple fracture, it is a complex fracture. So how do you know that whether it is a simple or complex? You will depend upon the classification. So there are very, very important classifications which are given for the fractures. So for example, the Hawkins classification. This is again a INICET bit which was asked recently. INICET 23 recently. Hawkins classification is for which bone? So here the answer is, it is related with the talus fracture. It is related with the talus fracture. So whenever you encounter or you see a talus fracture, you have to classify it based upon the Hawkins classification, right? Similarly, what are the other fractures which you have to remember their classification names? So again, a potential one-liners for the exam. So NExT classification is used for which fractures? So the fractures which is used is the fracture humerus. So NExT is used for the proximal humerus fracture. So here what happens is the NExT has divided this humerus, the proximal humerus, into 4 parts. Hence this is called the NExT classification into 4-part fracture. So if there is only one part which is damaged, like the greater tuberosity, the lesser tuberosity, the head, and the shaft. So these are the 4 parts, and based upon the fracture pattern, you decide whether it's a 1-part fracture, 2-part fracture, 3-part fracture, 4-part fracture. It is called the proximal humerus NExT 4-part classification. Then comes the Mason's classification. Mason's is for the radial head. So depending upon the Mason's radial head, grade 1, 2, 3, 4, you will decide the treatment or the approach towards that particular fracture. Then 𝐌𝐞𝐝. 𝐌𝐞𝐝 is for the femur shaft fracture. So 𝐌𝐞𝐝 has given as the femur shaft fractures based upon its pattern. So femur shaft is the prototype for the various patterns, like you can see the spiral, you can see the butterfly fracture, you can see the oblique fracture, the short oblique, long oblique, transverse, comminuted, segmental. All types of fractures can be seen in this femur shaft, and 𝐌𝐞𝐝 has given and described all these patterns. Then what is Pipkin's classification? Pipkin's is used whenever there is a dislocation plus femoral head fractures. So whenever there is a dislocation with femoral head fractures, you use this Pipkin's classification to decide the treatment. And again you have this Gardens and Paul. This is for IC fractures. Whenever there is an intracapsular fracture, you take the help of the Gardens classification and the Powell's classification for further management of the fracture, right? Then Rockwood is for AC joint. The acromioclavicular joint fractures are learnt according with your Rockwood classification. And Rockwood, this acromioclavicular joint again have been asked in the NEET PG and the INICT. So there is always a potential for accommodating this question. So something related to the AC joint can be asked in the upcoming FMGE, right? Next comes the Tile, Young and Bugress classification. So this is used for the pelvic fracture. So tile fracture, all the Young and Bugress is used for your pelvic fracture. So whenever you see the pelvic fractures, you will classify based upon the tile classification or the Young and Bugress classification. Then the adjoint, the lateral classification is for your acetabulum. So acetabulum fracture. So acetabulum fracture, whether the anterior wall, the posterior wall, the anterior column, the posterior column, or it is a bicolumnar or a V-shaped. So whatever it might be, this is based upon your Letourneur classification. So Letourneur and Judet are the ones who have been extensively worked on the acetabulum and has given us a classification to be followed there. Then Milch. Milch is for the lateral condyle of the humerus. So this lateral condyle classification, lateral condyle humerus is based upon the Milch classification. Then Long-Hansen, it is for the ankle fractures. So ankle fractures is the Long-Hansen classification, which has been used to they tell you whether it is in supination, pronation, supination adduction, supination supination and pronation, whether adduction or abduction injuries, right? So these are the various fractures which have been dealt with the given classification names, right? So this is also an important potential area where the questions can be expected, right? So that completes the classification. Important ones, the most important ones. Next, identify this particular image. So here we have come to treatment, we have come to that area that is now from the fractures. We have going to one more sector of orthopedics, which is called as the cold orthopedics, right? So here what happened is a patient is standing on single leg. If you can see, he's standing on the single leg, and probably this is the normal one because it is straight, and this is the abnormal one because there is a bend here. So there you can see a bend here. Whenever he's standing on this normal limb, there is no problem, but whenever he's standing on the abnormal limb, when there is a weight on the abnormal limb, then there is a bend which is seen. So what is this test indicative of? So this is nothing but your Trendelenburg test. So let us understand the Trendelenburg test, which is very, very important. So that this Trendelenburg test is used for testing the abductor mechanism. So the abductor mechanism of the hip joint are tested by this Trendelenburg test. So what are the abductors? So there are two important abductors, abductor medius, abductor minimus. Sorry, the gluteus minimus and the gluteus minimus, gluteus medius are the two important muscles which have been tested by this abductor mechanism. So the gluteus medius and the gluteus minimus, right? So these are the two important muscles which will be tested by this abductor mechanism. So what is this mechanism? So whenever you stand on the limb, if you can test for yourself, you're standing on the two limbs, right? Usually you stand on the two limbs and you will see that there everything is straight. So your hip joint or your pelvic joint, both the pelvic joints are at the same level. So why is this happening? Usually why this happens is because the pelvis is a structure which is a round structure, and both limbs are connected to one particular pelvis, right? So these two limbs with pelvis together form one particular unit. So whenever there is a problem in one limb, it gets represented in the opposite limb. That is not the case with your shoulders. That is not the case with your upper limbs. Upper limbs are independent of each other. Even if one limb is shortened, one upper limb, even if this damage, there is no effect on the opposite limb. But that is not the case with the lower limbs, because it acts as a unit. Because of the walking mechanism, because of the gait, it should act as a unit. The spine, the pelvis, and two lower limbs together act in synchrony for the normal gait. So for the balance also, they have to act in synchrony. right? So here what happens whenever there is an abductor mechanism which is damaged in the hip joint, this will result in the loss of the balance, right? So here what are they trying to show is the abductors, when they act, they pull this hip joint. So whenever there is no balance or whenever there is no support for a particular limb, the opposite limb abductors will take that charge and will try to pull the limb up, hence the limb is strained. But if this fails, if this abductor mechanism is failing, so these abductors cannot pull the load of the opposite limb, hence you see there is a dip in the pelvis. So whenever you see this dip in the pelvis, you have to say that, like, you have to note that there is a problem in the abductor mechanism of the hip joint. So whenever there is a problem in the abductor mechanism, so there are certain procedures which should be done to correct this abductor mechanism before performing certain high surgeries like your THR, your replacements. So you have to check for this abductor mechanism, right? So that is the Trendelenburg test, which is used for testing your abductor mechanism in case of the hip joint. So as we have learned the importance of the testing, right? We have learned the importance of the testing, that is the abductors are tested with the help of your Trendelenburg test. So there are various tests which are there in the orthopedics. So we will just go through the names of the test, right? So starting with these two, the Adson's and the Allen's test. So Adson's test is your nothing but your thoracic outlet syndrome, right? So thoracic outlet syndrome test, where the thoracic outlet syndrome is nothing but, you will also deal this with surgeons. So that general surgery also deals with this, the thoracic outlet, where the lower trunk get compressed. And now in this test, what you do, you ask the patient to turn to the same side, the affected side. Turning the head will compromise that particular area, which results in these symptoms, Now you check for your radius pulse. So that is the Adson's test, which is used for thoracic outlet syndrome. Next is your Allen's test. What is this Allen's test? Allen's test is used for testing the radial and the ulnar collaterals. So radial and the ulnar collaterals. So what happens is, in case of your hand, you will see there is one radial artery, then the ulnar artery, and there are a lot of collaterals which are present between this radial and the ulnar in the palm. So testing of whether this radial and ulnar artery are in working, so you will do this Allen's test. So once you block the radial artery, you will see that ulnar artery is taking charge over the filling the collaterals of the palm, and if you block the ulnar artery, you will see the radial artery will take the charge of filling of the collaterals in the palm. So this is called the Allen's test, which you test for the vascular supply of the palm. Next comes the important test, which is very, very important. This completes the sports medicine, that is the various tests which are used for the knee joint. So knee joint, you see all these tests which have been talking now. So all these tests for the knee joint. And if you remember, the knee joint, you have two ACL, you have two cruciate ligaments, that is one ACL and one PCL, right? So there are two cruciate ligaments, ACL and PCL, and then you have two menisci, the medial menisci and the lateral menisci, and then you have two collaterals, the medial collateral ligament and the lateral collateral ligament. So you have to remember the tests for all these ligaments and menisci, so hence you can deal with the various problems which have been encountered in the knee joint. So first, coming to the anterior drawer test. Anterior drawer test is used for your ACL, so anterior collateral ligament, which will prevent the subluxation of the tibia over the femur. So here the ACL is guarding the forward movement of the tibia, right? So here if you see, there is femur, there is tibia. So this is your femur with the watch one, and this is your down one is your tibia, right? So here whenever there is a flexion, whenever there is extension and flexion, there is the movement of the tibia O, right? So here what happens is, whenever the ACL is present, it will prevent the forward subluxation of the tibia, right? So in deficient ACL, so whenever the ACL is not there, you will see that the tibia is moving forward. But if the ACL is intact, the tibia cannot move forward. So this anterior drawer test is taking advantage of that movement, the forward movement of the tibia. So if you're trying to move the tibia front, and if we are able to move it easily compared to the opposite side, then you say that the anterior drawers test is positive, and this is the test for your anterior cruciate ligament. Similarly, there is a posterior drawers test. So you have ACL in the front and PCL behind. So PCL will prevent the posterior subluxation of the tibia. So PCL is preventing the tibia to move backward. ACL is preventing the tibia to move forward. So posterior drawer test is test for posterior cruciate ligament, anterior is for ACL, right? And next comes the pivot shift test. Pivot shift test is again for ACL, Latchman is again for ACL. So this ACL test which we have to remember, because Latchman is done in a relaxed manner. So now let us go into the details. So how to do the ACL test? So ACL, how it is done, you will flex the knee completely up to at least up to 90 degrees, and then you will try to subluxate the tibia. But when the patient comes with acute pain, you will not be able to flex this knee completely, right? So here what you do is you take the help of this Latchman's test, where you just hold the thigh in one hand and leg in one hand in that minimal flexion position, that is maybe up to 15 degrees, and then you try to do this maneuver of moving the tibia forward again. So you will try to move the tibia forward again, right? But now in the 15 degrees of flexion, but ACA this anterior draws test you do in the 90 degrees of flexion. That is the difference. So here the Latchman test, it can be done in the acute conditions. This can be done in the acute conditions. Hence the Latchman is supposed to be the sensitive test, and the pivot shift is supposed to be the specific test. So specific test for your ACL is the pivot shift. So pivot shift is nothing but taking MCL as the mother of the knee. So now you try to flex the knee, and then you try to internal rotate it, and while doing that you will see that there is a sudden jerk of the tibia. This is called the pivot shift. So this is very specific for ACL, and Latchman's is very sensitive test. Even it can be done in acute condition with the swelling of the knee. And then comes the Apley's grinding test and the McMurray's test. These two are the test for menisci. So there are two meniscus which are present between your femur and the tibia. And with the McMurray's is you try to flex it again, and you try to do the rotations, the internal rotations and external rotations with slight varus and valgus, which will cause pain. That is, the meniscus get crushed between the two bones, and hence this is the test for your meniscus. That is the McMurray's and the Apley's grinding test. Now comes the collaterals. The collaterals are the ones which are present extra synovial, right? There are extra articular, extra synovial. Like if this is your femur, this is your tibia, these are present somewhere here outside. So this is your MCL, this is your LCL, right? So if this is your fibula, this is your fibula. So MCL and LCL are seen on the outer aspect. And now what you do is give the stress test. So for the valgus and the varus, stress tests which are given at 30 degrees are very specific for your collateral ligaments. So when what is valgus, you will move it outside, right? Valgus is outside, and you're giving the stress to the MCL. So valgus is for MCL. The varus stress test is for your LCL. So varus test for LCL, valgus test for the MCL. So whenever you're trying to open, so valgus or varus is nothing but you're trying to open that particular component, or medial component or lateral component. So when are you trying to open the lateral component, that is you're giving the varus stress towards inside, and you see there is an opening on the lateral component, that means there is a problem with the LCL. So LCL is allowing it to open on the lateral side. And similarly, you're giving a valgus stress, and you're trying to open the medial side of the knee, medial compartment. Hence, you are trying to give stress to the MCL. So MCL, LCL are the collaterals which will be tested based upon your varus and the valgus stress. ACL, PCL are tested by your anterior drawers test, and then the ACL specifically by Latchman and the pivot shift test. And for meniscus, you have McMurray's test and the Apley's grinding test. And now comes for the shoulder. So shoulder dislocation is one important topic where you see there are few tests which you have to remember. So one is your Dugas test, the Hamel-Runel test, the Callaway's sign. So what is the Dugas test? Dugas test is what you do is you try to touch the opposite shoulder. So if this is the shoulder which is damaged, or if you encounter dislocation in this particular shoulder, you try to touch the opposite side, and if you are unable to touch the opposite side, this is called the Dugas test. So this is the Dugas test for anterior dislocation of the shoulder. Anterior dislocation of shoulder. So KP Chowdhury, this is all important. Everything is important. We are discussing only the important things. So again, in this, if you want more important, it is little more difficult for me, but I will again try to do that also. So here in the shoulder, you can remember the Dugas test, and here what you can remember is the anterior drawers, the pivot shift, and the Latchman. So these are usually frequently asked, and the McMurray's is for the meniscus. So these are again important ones, and here again the important ones come with the Cousins and the Finkelsteins, right? So here the Dugas was for shoulder dislocation, where you see the anterior dislocation of the shoulder. The Hamilton ruler is the one which is used for again it's a shoulder dislocation, where you put the ruler on the acromion and the lateral condyle, and if it is a straight line, you see there is no dislocation, but if there is not a straight line, then there is a dislocation, right? Callaway is for the axillary circumference. So whenever you see that there is the axillary circumference which is increased, obviously whenever the humeral head is coming outside, you see that there is an increase in axillary circumference. So that is the Callaway's test. So these three are important for your shoulder dislocations. And now coming to the most important one, that these two tests, the Cousins test and the Finkelstein's test. The Cousin test is for your tennis elbow. So you all know the most important one, the tennis elbow, and then the Finkelstein is for the 𝐑𝐄𝐝 stenosynovitis, right? So 𝐑𝐄𝐝 stenosynovitis is nothing but your APL, EPB. These two are the tendons which are involved in the 𝐑𝐄𝐝 stenosynovitis, and tennis elbow is nothing but your lateral epicondylitis. So whenever there is a pain on the lateral epicondyle and doing this Cousins test. So what is this Cousin test? You will make a fist and you will try to extend it. So on extension, what happens is you see the pain on the lateral epicondyle, because all the extensors are attached to a lateral epicondyle, right? So this lateral epicondylitis, inflammation of the lateral epicondyle, which is tested with the Cousins test, and if it is positive, you call this as the tennis elbow, right? And similarly, there is APL and EPB on the thumb aspect, and here this is the first extensor compartment of the wrist, that is the abductor pollicis longus, extensor pollicis brevis, and now this is called Finkelstein test, where you try to put the thumb inside and then make a fist and then you try to extend it. You will find a pain. So this is called the 𝐑𝐄𝐝 stenosynovitis, and this particular test is called the Finkelstein's test, right? So that is for your both important, your tennis elbow and the 𝐑𝐄𝐝. Now coming to the Barlow's and Otterloni, this all I think you're very familiar. This is for the DDH, that is developmental dysplasia of the hip, where you see Barlow that is getting out and Otterloni is putting inside, right? So here what happens is the patient presents with the usually you will see the risk factors, whether it is a firstborn female, breech position, and if you see there is an history of DDH, you will try to do this screening test for the newborns, which is called as Barlow's and Otterloni, where you will try to abduct and flex the hip first, and then try to abduct it, bringing your femoral head outside the socket. And if you are able to do, if you able to hear that clunk sound while getting it out, that means this is DDH positive. And then Otterloni is again you're trying to put inside it. Why you're trying to bring it out and putting in? So here what happens is the DDH is nothing but a spectrum. So sometimes you may encounter already the heads are inside it, but now if you try to do it, try to pull them out, and if you are able to succeed in that, that means it is DDH. Sometimes you see the heads are inside and you don't think that is normal. You have to do this screening test, that is Barlow's and Otterloni, right? So this is called the DDH, the developmental dysplasia of the hip, and these two are the important screening tests which you have to do, the Barlow's and Otterloni. But what is more specific, what you have to do is the ultrasonography. So the ultrasound is most important in case of your DDH, right? And last but not least is the Thomas test. Thomas test is for identification of the fixed flexion deformity of the hip. So this is again very important. The fixed flexion deformity, or nothing but there is a problem in the hip. For example, if a patient is having TB hip, or if a patient is having rheumatoid hip, so here they comes with the pain in the hip joint, and now you see there is this hip goes into flexion, and now that is compensated by the lumbar lordosis, right? So now that is compensated by lumbar lordosis. As I've already told you, the spine, the hip and the two limbs are all connected. They act in synchrony. So whenever there is a problem in the hip where the flexors are not able to do their job, but now what does that do? Now what happens is the spine takes their duty. The spine will tell, okay, I will exaggerate my lumbar lordosis so that there will be some compensation for the flexion. So now what we have to do, we have to tell the spine, okay spine, you please relax, so that we'll just test the hip joint. So now we will put the you will put the patient on a table on a supine position, asking the spine to relax. How do you do that? You will try to flex the normal hip, telling that everything is normal. Now the spine will relax. When the spine relaxes, now the hip flexors goes into more flexion, and now you can see the fixed flexion. So this is called the Thomas test, identifying the flexion deformity, that is the which is present in the hip joint. So this is the flexion deformity. After relaxing the spine, you will able to see the flexion deformity, and you will measure it with your goniometer and write the flexion deformity. So this is very, very useful to identify the flexion deformity. And this flexion deformity, the abductor mechanisms, these are all important to plan your surgery. Plan and execution of the surgery is very important. So this is all the pre-operative planning for surgery. So the Thomas test is again very, very important. So this is Thomas test, which is very, very important. So these are all the test names which you have to remember. Hardly there are some 15 or 16 like that. Okay, so that is about the test. And now coming to the one more important image. Yes, Raj, DIP activities, you can ask what is your question. Okay, by the time he types the question, let us complete this. So this is again an image, very, very important image, has been asked in previous NEET PG, the INICT, FMEG, every exam, whatever you name them. So this is nothing but the, yes, the Shepherd-Crook deformity. So this is the Shepherd-Crook deformity, where you see this. You see this in a condition which is called as the fibrous dysplasia. So this is fibrous dysplasia, a condition where the bone is being replaced by the fibrous tissue because of the what was your question, Raj, DIP? Okay, so now, yeah, yes, that is the fibrous dysplasia. So this fibrous dysplasia is nothing but where you see the ground glass appearance also you see. So this is the ground glass appearance or the fibrous dysplasia, which is called the Shepherd-Crook deformity. So this is the Shepherd-Crook deformity usually seen in the proximal femur, right? So this is a condition. And what you have to remember, this is a polyostotic condition. So this is the polyostotic condition, and whenever it is associated with other symptoms, it is called the McCune-Albright syndrome, right? So this is polyostotic, which means there are multiple areas where you can see this condition, that is the Shepherd-Crook deformity, the fibrous dysplasia. And it is associated with other hematomas, which is called as the McCune-Albright syndrome. Very good, Adarsh, it is McCune-Albright syndrome, exactly correct. And now, I think previously they have asked about cubitus, varus and valgus. Now, let us deal with some of the deformities here. So, as I've already told you, this is the Shepherd-Crook deformity you see in case of your fibrous dysplasia, right? So, fibrous dysplasia is a condition where you see the Shepherd-Crook deformity and where you see the cubitus varus and cubitus valgus, right? So, cubitus varus is seen in the supracondylar fracture. So, what is cubitus? Cubitus is nothing but the elbow. Yeah, McCune-Albright syndrome is precocious puberty with fibrous dysplasia. Very good. And then in cubitus varus, you see the supracondylar fracture humerus were not treated properly. It is called the cubitus varus. So here you see the supracondylar fracture humerus, and cubitus valgus is seen in the lateral condyle fracture. So lateral condyle fracture. What is the most important? Another thing of this is you will see what is called as the tardy ulnar nerve palsy. So the tardy ulnar nerve palsy is seen in the lateral condylar fracture, right? So the cubitus varus, cubitus valgus, yes, rickets also you can see in cubitus varus. So rickets is usually the weight bearing area, such as you mostly see the genu varus and genu valgus in case of rickets. So cubitus varus usually occurs in case of the supracondylar fracture, where this fracture is not treated properly will result in this varus condition, which is also called as the gun stock deformity. So this is very again a image based question, the gun stock deformity, and that is because of the cubitus varus. And then you have your cubitus valgus, where you see the lateral condylar fracture, and one more important complication associated with this is the tardy ulnar nerve palsy. Then comes the genu varus and the genu valgum. Genu varus is very, very important, which is seen in a very important condition which is called as osteoarthritis and rickets. Very, very important rickets. And then you can also see in Blount's disease, which is nothing but your tibia vara. So tibia vara in case of Blount's disease, genu varus is seen in case of osteoarthritis and the rickets. And valgus, genu valgus is predominantly seen in your rheumatoid arthritis or in some particular trauma, right? So in traumatic condition also you see this genu valgum. So rheumatoid arthritis is one such condition where you see this genu valgum. And now the important thing is, what is triple deformity? Triple deformity is nothing but, you can remember this, it is seen in various conditions. So this is seen in TB, this is seen in rickets, this is seen in iliotibial contracture, right? And then it is seen in polio, and it is seen in hemophilia. It is seen in hemophilia. So this is the triple deformity. And what is actually triple deformity? Where you see flexion of the knee, right, with subluxation, posterior subluxation with external rotation, right, with external rotation of the tibia. So subluxation of tibia, usually the lateral subluxation with the flexion with the external rotation. So all these three to put together are called the triple deformity, and this triad is seen in all these conditions. All these conditions such as your TB, rickets, iliotibial, polio and hemophilia. So all these are seen in case of the triple deformity. Others shall come to your question later. Once I complete this table, I will tell you what is that, right? So next is the windswept deformity. So we are dealt with the triple deformity. So it is seen all this condition, right? And what is windswept deformity? Windswept deformity is one such condition where you see that there is a varus in one leg and valgus in another knee. So varus in one knee and valgus in another knee, which is again a classical example for rheumatoid arthritis. This is called as the windswept deformity is nothing but again both varus and valgus, which is seen in rheumatoid arthritis, and it is also seen in rickets. So rickets also you see this windswept deformity, and you will see this in rheumatoid arthritis. And then what are the two most important deformities? Again, one is the dinner fork deformity, the second one is garden spade. So dinner fork deformity is nothing but your malunion of the distal radius. So what is malunion? Malunion is nothing but where you see that the union is there is a very much union is present, but it is not aligned properly. So whenever there is a malalignment of this union, which will result in a deformity, this is called as a dinner fork deformity, which is seen in case of distal radius, especially a complication of the Colles fracture, especially the complication of the Colles fracture, right? And then garden spade, yes, it is a Smith fracture. Whenever the Smith fracture goes into malunion, it will result in this garden spade deformity. So one is dinner fork, the second one is garden spade. So these are the certain deformities which you have to remember, right? So that is about the that is about the deformities and the parts involved. Now coming to the other question. So he was asking about gunstop deformity occurs due to which class of Salter-Harris fracture. So here what you have to remember is in case of Salter-Harris, there is a damage to the growth plate, right? So the growth plate is damaged, and now this will result in the formation of the gunstock deformity. So the one part is getting involved. So this Salter-Harris classification is especially this is the, it could be the type 1, that is the, see, if Salter's classification is the 5 grades, right, 1 2 3 4 and 5, and this is the, usually it will fall in the type 2 of Salter-Harris classification, right? So that is the involvement of the metaphyseal spike, and then because of the reduction not being done properly, it would result in this gunstock deformity, right? I hope that completes your answer. Next, we are going to deal with the tumors part. So here till now we have completed the deformities, and now we are going to deal about the tumors part. So here here in the tumors, what is most important is in exam usually the tumors are mainly the imaged based questions, right? The imaged based questions are these tumors. So here we have to understand the image, and then you have to answer it accordingly. So how do you come to a conclusion for which tumor does it belong to? Right? So once you see the lesion in the x-ray, so if at all you are encountering an x-ray and you see the lesion, first you have to divide whether it comes into the epiphysis part, the metaphysis part, or the diaphysis part. So epiphysis, if you see the lesion in epiphysis, there are two important tumors which you have to remember is the giant cell tumor and the chondroblastoma. So these two are the important tumors which occur in case of your epiphysis. So giant cell tumor is also called as your osteoclastoma. It is also called your osteoclastoma, and the chondroblastoma is nothing but the tumor which is seen in case of cartilaginous tumor. So this is the cartilaginous tumor which is seen, and it is usually occur in the epiphyseal region. So if you see a lesion in the epiphysis, you will see these two, that is the giant cell tumor and the chondroblastoma, right? And then coming to the metaphysis. Metaphysis is very, very important because in the metaphysis there are numerous tumors which can be seen. So for example, the most important one is your osteosarcoma. Then you have your osteochondroma, right? The osteochondroma. Then you are your ABC, or the simple bone cyst, the aneurysmal bone cyst, and then the non-ossifying fibroma. And there are again certain tumors which can be seen in the metaphysis, right? Again, in the diaphysis, what you have to remember is the most important one is the Ewing's sarcoma. So in diaphysis, there is Ewing's sarcoma and the osteoid osteoma, right? Ewing's and the osteoid osteoma. So these are again occurring in the diaphyseal region. So what is more important here is in the epiphysis there are only two tumors which you have to remember, that is the giant cell tumor and the chondroblastoma. And the metaphysis, you are numerous because the most common area is the metaphysis for the infection and also for the tumors. For example, your osteosarcoma or osteochondroma, your aneurysmal bone cyst, your simple bone cyst, your non-ossifying fibroma, they are all occurring in this particular metaphyseal region. Your edemantinoma, right? And then come the diaphysis part. There are again restrictive, such as your Ewing sarcoma, your osteoid osteoma. These are specific for your diaphyseal part, right? So that is how you first decide whether these tumors are occurring in the epiphysis, the metaphysis, or the diaphysis part. Okay, and now there are certain important signs on the x-ray which you have to note, and there are certain radiological signs. So for example, the osteosarcoma, they present with what is called as the sunburst appearance, and the Codman's triangle. So sunburst appearance and the Codman's triangle, these two are seen in case of your osteosarcoma. And what about osteochondroma? Osteochondroma is nothing but, you see, there is a sessile or pedunculated. It is nothing but the bony growth. The bony growth which occurs at the metaphyseal region is nothing but your osteochondroma, where you see it is covered by the cartilaginous cap, right? And you can see that this is something like the stalk. So it is something like this. So this is your osteochondroma, usually occurring in the metaphyseal region, and usually they are seen in the distal femur part. So femur part in the distal femur area around the knee joint, right? And this is nothing but the extra growth of the bone. And coming to the Ewing sarcoma, very well you know this is the onion peel appearance. So the onion peel appearance is nothing but your Ewing's sarcoma. And chondrosarcoma, you see the popcorn calcification, So here, because this is a calcified cartilage tumor, so because of the cartilaginous tumor origin, it is seen as a popcorn calcification or comma calcifications. So these calcifications are seen in chondrosarcoma. Very, very important, giant cell tumor is your soap bubble appearance. So you will see the soap bubble appearance in case of your giant cell tumor. And osteoid osteoma, you see this as the nidus. You see a nidus and a small area in center. So you will see this as nidus. And what is most important of osteoid osteoma is it is treated with aspirin. So whenever you give this test dose of aspirin, whenever you give aspirin and then the patient feels better, the nighttime pains, the night cries are usually seen with osteoid osteoma, and these are relieved by the aspirin because of the release of the prostaglandins, right? And again, all the cartilage tumors, you will see the calcifications, which can be again be like a popcorn shaped or a comma shaped calcification. So whenever the cartilage origin, you have to look for this calcifications, right? And what is multiple myeloma? Multiple myeloma, you see it as moth-eaten appearance. The moth-eaten appearance is seen in case of your multiple myeloma. Then fibrous dysplasia, as I've already told you, it is the ground glass appearance, or the shepherd crook deformity which is seen. The simple bone cyst is usually seen as a simple cyst like this, a simple lesion which is lucent, and then if there is a fracture which is associated with this, you see what is called as a fallen leaf sign. So this is the fallen leaf sign. So you will see a cyst like thing, that is the lucency, and you see a small fragment which is present inside that lesion. That is called the fallen leaf sign whenever the simple bone cyst is associated with the fracture, and this is called as a pathological fracture. And what is aneurysmal bone cyst? The bone cyst, you see the multiple fluid levels. So you see this multiple fluid levels in case of your aneurysmal bone cyst. And metastasis, again you see the winking oval sign. So the winking oval sign is seen in case of your metastasis, so especially in case of the spine. So metastasis, and most commonly where you see the most common bone which is involved in the metastasis is vertebrae, right? On the vertebrae, what you see is the pedicle. So these are the two pedicles which you see on the vertebrae, and whenever you see one pedicle is completely, so you see this as the winking oval sign. So you see this closure of like one eyelid or one eye. So this is called the winking oval sign. And then the polka dot sign. The polka dot sign you see in hemangioma. So this is a tumor-like condition. Again, it is seen in the vertebrae, and you will see this as on the CT scan. You see this as the polka dots. Right, so this is the polka dot sign, or again you have this corduroy appearance. So the corduroy appearance, the polka dots is a sign of your hemangioma, right? So these are the various signs which you have to remember in case of your tumor conditions. Like these are all the tumors and their specific radiological features which is seen on the X-ray. So these images of this particular X-rays will be dealt again in radiology. That is why I have not put up all the X-ray features here. I'm trying to tell you what are the important things about each, right? And now there are specific sites for each fracture which are very, very important. For example, if you see chordoma, if you see, you will mostly encounter this in sacrum. So if you see something in sacrum, you can tell that as it could probably be chordoma. And again edemantinoma. Edemantinoma again you see in case of mandible. So mandible is one area where you see this edemantinoma. And again enchondroma. Enchondroma you see in small bones such as your hands and legs, feet, right? So this is the hands and feet, that is enchondroma. This enchondroma is again a tumor which occurs in the metaphyseal region. And similarly osteoma. Osteoma you see in skull. So usually the skull, the facial bones, they produce this type of osteoma. And then your osteoblastoma, osteoidostoma, osteochondroma, all most common is your femur, especially the distal femur, right? And again SBC. SBC is simple bone cyst which is specific for humerus, especially the proximal humerus. So proximal part of the humerus you mostly see the SBC, and ABC is again your lower limbs. So lower limbs, especially the knee, the proximal part of the tibia. So that is how you will come to conclusion with the certain tumors. For example, if they give you an X-ray of the hand with a ballooning sign, so if you see there is an expansion, so then you can put the enchondroma as one option, and if you see a sacrum, you can put chordoma as one option. And similarly, if you see any lesions in the epiphysis or the meta or the dia, you can tell them based upon this location, right? And any of you know the radiological signs, the suburban appearance. If there is a epiphyseal tumor with the suburban appearance, it is nothing but the GCT. If you see the sunburst appearance in case of your femur or the tibia, in the metaphyseal region, it is your osteosarcoma, right? So these are certain tumors. And now coming to the joint disorder. So these are the two important next is your that topic, enchondroma, PYQ thumb. PYQ, yes, it was a previous year question which was asked, that is enchondroma. That was example I was quoting right just now. That is the hand X-ray has been shown, and if you see any tumor on the hands, the first diagnosis should be your enchondroma. That way the particular table will be important. Now coming to the joint disorders. So here I have put up two important X-rays for you, and let us now deal with the X-rays, right? So here the first X-ray, this is your knee joint, right? So this is the knee joint X-ray. Similarly, this is again a knee joint X-ray. But what you see here is there is a decrease, that is there is a joint space narrowing on one part. So this could be the medial compartment and this will be your lateral compartment. And the first thing what you observe is the joint space narrowing, and you will see there is a sclerosis, that is whitening here, and you see some amount of osteophytes which are seen here, right? And there is a slight deformity which you can see, right? So all this, so the main important thing is your joint space narrowing. The joint space narrowing is seen both in osteoarthritis and the rheumatoid arthritis, and what is specific for osteoarthritis is the sclerosis. The sclerosis, the subchondral sclerosis which you see here, the subchondral sclerosis is very, very important for the diagnosis of your osteoarthritis. And what is even more important than that is your osteophytes. The formation of the osteophytes is very, very important. So whenever you see osteophytes with subchondral sclerosis, and ultimately they will result in this deformity. If you can see, there is a slight varus deformity. So all this point towards your osteoarthritis. So what is osteoarthritis? Osteoarthritis is nothing but a degenerative disorders. This is a degenerative disorders that is wear and tear mechanism. So it's a worn out compartment, right? It's a worn out compartment, that is a degenerative, and usually you will see it is in the medial compartment because the weight bearing part is the medial compartment, right? And then they're usually present because of the involvement of the medial compartment. Usually they present with varus, and what you have to remember is the hand, PIP and DIP joints are involved, which are called as the Bouchard's and the Herbedens nodes. The Bouchard's nodes and the Herbedens nodes, which are seen in case of your osteoarthritis. So the both PIP and DIP, the wrist, what are spared in this? The spared are your wrist and the MCP. So the wrist and the MCP are spared. What are involved is the PIP and DIP, that is the Bouchard's nodes and the Herbedens nodes, which are involved in case of your osteoarthritis, right? So that is how what you have to remember. And in case of rheumatoid arthritis, so this is nothing but your rheumatoid arthritis, right? So this is your rheumatoid arthritis. What you see on rheumatoid arthritis? So here you can see again there is a joint space narrowing, but what is more important is there is an involvement of the lateral compartment. So here what is important for us is again the joint space narrowing which is there, and then what is important is juxta-articular osteoporosis. Juxta-articular osteoporosis, and even more important is the erosions. There will be erosions, there will be destructions, right? So you will see destructions, you will see erosions, and juxta-articular osteoporosis which is seen here very clearly, and involvement of both the compartments. So both the compartments are involved here, right? And what is important here, again there is involvement of hand and the smaller joints, especially the MCP joint is involved along with the PIP, the DIP and the wrist joint. So all these joints are involved, and the involvement is bilateral, the involvement is symmetrical. So these are all the features which are pertaining towards your rheumatoid arthritis. So it is a bilateral involvement of the joints, symmetrical involvement of the joints, and you can see there are a lot of erosions, the destructions, the juxta-articular osteoporosis, osteopenia which is seen around it, right? And this is so typical of the rheumatoid arthritis, right? So the joints, everything is involved here. And then comes your psoriatic. So psoriatic is the one which mainly involves the DIP. So the DIP joints are involved, and what is the pencil in cup appearance? So the distal phalanx is completely lost, and you will see that is a thin rim of the cortex which is called the pencil in cup appearance, and psoriatic is mainly associated with the distal interpharyngeal joint. So DIP is involved in case of psoriasis, right? So DIP is paired in case of your rheumatoid. So sometimes it is paired in case of your pencil tip appearance, right? So this is about your rheumatoid and your osteoarthritis. And one more I want to cover is the gouty arthritis. So one more you have to cover is the gouty arthritis. So gouty arthritis is mainly, you see, this is associated with the alcohol, consumption of alcohol, and then you see the involvement of the first MTP joint, and here what happens is whenever the knee is involved, it is swollen, that is acute gout, it is completely swollen and it is red, and it usually mimics the infection, right? But it is mainly because of the increase in the serum uric acid level. So there is an increase in the serum uric acid levels. So that is about the gouty arthritis, psoriatic arthritis, and then your rheumatoid arthritis and your osteoarthritis. So this is about the joint, and this joint disorders can be diagnosed based upon the synovial fluid analysis. So whenever you do a synovial fluid analysis, you can find there are uric acid crystals. So this uric acid crystals are negatively birefringent, right, on the polarized light. So on the polarized light, what you see, the needle shaped negatively birefringent crystals are seen. And similarly, you have pseudo gout, where it is a positive crystals which are rhomboid shape, so that is CPPD. This is pseudo gout. So that completes your joint disorders, right? A bit of it, little important things, right? And now coming to the another important chapter, that is again a imaged based topic, that is about your splints and tractions, which are very specific for orthopedics, no overlap with other departments. So here you see some specific orthotics which you can see, and this is called the ash brace. So this is your ash brace. It is called the anterior spinal hyperextension brace, which is used for correction of the thoracic kyphosis, especially in the thoracic part, upper thoracic part. And here you see another important one, yeah, pseudogoid rhomboid shaped, it was being discussed. And this is the second one, that is your Taylor's brace, and this is very important for us because it is used in case of your TB spine, so tuberculosis spine. Here you see this particular brace which is used. This is called both for dorsal and lumbar. So lower dorsal, upper lumbar is been protected by this, so this is called the Taylor's brace, right? And what is the third one? The third one is your foot drop splint. So this is your foot drop splint. So we have learned that the common peroneal nerve which is involved, which is resulting in the foot drop, and to prevent that foot drop you use this particular splint which is called as the foot drop splint, right? So these are the three important braces. And for scoliosis you have two important braces which you have to remember. One is the Milwaukee brace, and then you have your Boston brace. So these two are important. So today you go back and you check on the net what is Milwaukee and the Boston brace. You will remember it by yourself, right? So this is Milwaukee, Boston, which you're going to read soon after this class. And then you have your ash brace, the Taylor's brace, and the foot drop splint. So after this, I will tell you what is Thomas splint, okay? And now what are these? These three are very, very important. So first one is your knuckle bender splint. So knuckle bender splint, where do you use them? Knuckle bender splint is used for your ulnar nerve palsy. So this is your knuckle bender splint which is used for your ulnar nerve palsy. And then this is VIC splint, the Workman ischemic contracture splint. So this is used for Workman ischemic contracture. So this is your VIC splint. And now this is your dynamic cock-up splint. Dynamic cock-up splint. So this is your dynamic cock-up splint. Where do you use this? This is used in case of your radial nerve palsy. So radial nerve palsy, as I've already told you, that there is a wrist drop. So this wrist drop is prevented. So you see the wrist is dropped like this, and now what you do based upon the splint, you try to do flexion and extension. So you are keeping the tendons active. So that is what the splints are used for. You keep the tendons active even without the stimulation of the nerves. You have to keep the tendons dynamic, otherwise the tendons will wither off, and even after repairing the nerve, you don't see the tendons functioning. So this is also called as turnobuccal splint, right? VIC, it is used for VIC, the turnobuccal splint. So these are the splints which are most commonly asked in case of your upper limb. These are the splints for spine and the lower limb. And finally you have this splint which is called as the aeroplane splint. This is used for your brachial plexus injury. So you will use this for your brachial plexus injury. This is called the aeroplane splint, right? So this is your aeroplane splint. And now there is one more splint. This is called the Thomas splint. So this is your Thomas splint, where you have this to accommodate your GT. So there is a ring-like structure. So this is your ring-like structure, right? And this ring for the thigh, and you have two rods which are joined in shape like this, And now whenever you want to accommodate the patient, what you do is you will put the layer of bandage across this, right? And then you will be using for this for the immobilization of the patient mainly with the femur shaft fractures, right? So this is about the Thomas splint. But Thomas splint was invented for treating of the TB patients, for immobilization of the TB patients, but now they use this for mainly for the femur shaft fractures. You will place the limb here, and this can be used as a facilitator for shifting the patients. So this is the Thomas splint, right? Very good. And now let us deal a little bit with the metabolic disorders and hormonal disorders. So once we are done with the splints, now let us deal what is osteoporosis. So you all know this is also one more important topic which has been recently asked. So they have been specifically asking about the DEXA scan. So before that, let us understand what is osteoporosis. As you all know, it is a disorder of where there is a decrease in the bone mineral density. So the bone mineral density is decreased. Why does it decrease? It is decreasing in the post-menopausal woman, though you already know that the estrogen plays an important role in the female bone mechanism, the female dynamics of the bone. But whenever there is a decline in the estrogen, there will be a decline in the mineral density. Hence, there will be weakening of the bone. The trabeculae get widened. Hence, the patient is prone for fractures. So this DEXA scan is nothing but dual energy X-ray absorptiometry, where you use a lower dose of the screening X-ray machine, where you will identify the patient's bone mineral density. And now these are nothing but they are the deviations. So based upon the standard curve, you will decide the deviation, and if this is less than 1 2.5, sorry, less than minus 2.5 deviations, you will declare this patient as osteoporotic female, and you will put on the treatment, right? And if it is less than 1 minus 1, you can treat it as osteopenia, and you can simply do the prophylactic treatment for the osteoporosis. Now this is nothing but the T score which we take into account, not the Z score. So whenever you have the standard curve, you have two T scores and the Z scores, right? So you were taking into account the T score here, and you will compare it with the individuals of that particular age, right? And now what you see is if there are deviated 2.5 times deviated, then you can you call this as osteoporosis. And if it is more than 2.5 with the fragility fractures, such as your distal radius fracture, your hip fractures, your vertebral fractures in specific for osteoporosis, this is called for osteoporosis. So when do you do this DEXA scan? DEXA scan usually is done for 60 years for females according to the national screening protocol, and 75 years male, or if they have any history of fractures, you go for the DEXA scan, right? So this is the DEXA scan which is being used, and usually this is the measure for the bone mineral density. Based upon that, you can start the treatment. The treatment includes certain bisphosphonates which are very available right now. So these bisphosphonates are your alendronate, risendronate, right, ibandronate, and zoledric acid. So these all will do decrease in the resorption, and they will increase in the formation of the bone. So here what you have to remember is the bone dynamics is everything, the balance between formation and resorption. Whenever there is an increase in the resorption, the bone becomes weak, right? So we are trying to provide with anti-resorptive measures. So all this bisphosphonate does these anti-resorptive measures. Some does both formation and resorption, that is the zoledric acid. So alendronate, risendronate, ibandronate, these are the drugs or the bisphosphonate which have been approved for the treatment of your osteoporosis, right? So now let us deal with a few x-rays which are very important in case of your vertebral. So the first one is called the codfish vertebrae. This is called the codfish vertebrae. So what is this codfish vertebrae? This is mostly seen in case of your osteoporosis. So osteoporosis is the codfish. If you can see this particular vertebrae here, so this is the codfish appearance, right? So this is the codfish appearance. So usually the the appearance of the vertebrae is something like this, where it is equivalent on the anterior and the posterior aspects. But here if you see, there is a thinning or the decline in the anterior aspect, right? So this is called the codfish vertebrae or the codfish appearance, which is seen in case of your osteoporosis. And the second one is your rugged jersey spine. So this is called the rugged jersey spine, and this is seen in case of your hyperparathyroidism. So hyperparathyroidism is the one condition where you see rugged jersey syndrome. It can also be seen in the Paget's disease. So what is actually this? There is a formation. So here you see some bone which is present, and here you see the area of lucency, and then again you see the bone. So this is the bone, and then there is a lucency. So this appears as the rugged jersey spine, which is similar to the jersey which has been put across the image. So this is the rugged jersey spine specific for hyperparathyroidism. Very good. And the third one is the picture frame vertebrae. So picture frame vertebrae is the vertebrae where you see all the ends have been sclerosed, and you can see the center is lucent. So the center is lucent, the ends are sclerosed. So this is called the picture frame vertebrae, and this is specific again for your Paget's disease. So this is again a disease of elderly which you see, where there is an increased amount of sclerosis, right? But this sclerosis is not useful because the bone is not strong, right? So this will result in what is called as the picture frame vertebrae. So these three are very, very important: the codfish vertebrae, the rugged jersey spine, and the picture frame vertebrae, right? And one more thing in spine, what you have to remember is the bamboo spine. So bamboo spine and the dagger sign, this is your homework. So bamboo spine, the dagger sign, right? All this is seen in ankylosing spondylitis. You see this in your ankylosing spondylitis. So this you go back home and you will check for yourself. So what is the dagger sign and what is the bamboo spine? The bamboo spine is nothing but there is a formation of the syndesmophytes on the spine which fuse together. Then this is called as a presentation the bamboo spine. And the dagger sign is the ossification of the longitudinal ligament. Both the images you go back home and check for yourself. So these are all the conditions which are usually asked in the exam: the codfish vertebrae, the rugged jersey spine, the picture frame vertebra, the bamboo spine, and the dagger sign, right? So these are all the images which you have to remember. And now I'm then coming to this particular image, what you see here. So here what you see is your blue sclera, right? So this is your blue sclera. So whenever this is associated with multiple fractures in case of children, this is a condition which is pointing us towards the osteogenesis imperfecta. So this is a condition where there is a defective collagen. There are two important 𝐂𝐴1 and 𝐂𝐴2, which are the two genes which are defective, and because of the defective collagen, there is multiple fractures which are occurring in the child. But what you have to remember is the union is normal. So the bones heal. They heal normally, but there are multiple fractures even with the slightest of trauma, like trivial trauma, which results in the fracture. So there are multiple fractures which are seen in the X-ray, and multiple stages of healing on the X-ray with the dentagenous imperfecta, with the blue sclera. This is a triad of osteogenesis imperfecta. This is a triad of osteogenesis imperfecta, a condition which is seen in children with multiple fractures. Then what is this? This is yellowish teeth which is seen, and this is the indication of one common condition which is called as fluorosis. Arman, what is sure? So this is the fluorosis which we see here. The fluorosis is nothing but the fluoride component which is high. Fluoride component which is high. This fluoride is which gets accumulated as calcium hydroxyfluorate, and this is not going to resorb. This is very resistant for resorption. So as I've already told you, the bone dynamics is all about formation and resorption. So bone forms, then the osteoclast comes and eat away the bone. Again, there is a new bone formation. But whenever there is a fluoride which is present here, it will not allow the osteoclast to eat on itself. So now the bone becomes sclerosis. There is a strong bone which is present, but it is a brittle bone, right? So it is a brittle bone. It is the osteosclerosis which we see in case of a fluorosis. So this is osteosclerosis, and mostly what we see is here the red the yellowing of the teeth. So the yellowish teeth which we see, and you see that the serum fluoride levels are very high in particular patients, which will result in this condition, which is called as fluorosis, right? And then the two important conditions which you have to remember is, one is the rickets and the second one is the scurvy, right? So one is the rickets, the second one is the scurvy. So what is rickets? Again, there is the decrease or vitamin D deficiency, hence there is the defective mineralization. So there is a defective mineralization, and then hence the patient will result in what is called as multiple symptoms, right? If you can see in the infant, you can see in the newborn. So there are multiple symptoms which are seen in the rickets. So mostly what we do is, first you analyze the patient for vitamin D levels, and then you take the x-ray of the wrist joint. This is how you have to evaluate. So this x-ray of the wrist joint you take on the bilateral, both the sides, you take on both the sides, and what you see is this particular x-ray. So this is the condition of the rickets, where you see there is a cup like metaphysis. So this is called cupping, and you can see the ends are not it is equal in there. So this is called fraying, right, and splaying. So cupping, fraying and splaying, where you see cup-shaped metaphysis, where the fraying, you can see the small amount of, the ossifications which we see here, fraying and the splaying all together, what is called as the rickets, which is seen in the metaphysis, because that is the area, that is the growth plate where it is defective. So the growth plate is defective, and now this will present with the various deformities, that is genu varus mainly, and it could also be genu valgus. And you can see that in case of infants, they will see that the fontanelles are not closed, so the delayed fontanelles, or you can say rachetic rosary, that is the junctions of the sternum with the ribs. The sternum with the ribs, the junctions will get swollen. You can see them as the rachetic rosary. So these are all the various symptoms of the rickets. So what do you do with the rickets? You actually treat them vitamin D directly. So this is vitamin D which you give to the, and then with the calcium. So vitamin D plus calcium supplements to be given to the patients with the rickets, hence they heal, right? So now the growth plate starts healing, then there will be mineralization, and then there will be reversal of all this cupping, fraying and splaying. So this is very, very classical of rickets. So this is the classical picture. So what is scurvy on the other hand? Scurvy is nothing but there is a vitamin C deficiency. So why is this vitamin C important for us? Vitamin C is important for the cross-linking of the collagen again. So there, in case of osteogenesis imperfecta, the collagen itself is defective, but in case of scurvy, the cross-linking of the collagen is by your vitamin C. When this is defective, again, there will be certain conditions such as bleeding gums. So because of the weak collagen, there will be bleeding gums, and again, the bones will become brittle, the bones will become weak. And here, what are the signs which you see here? So you see here what is called as the white line of Frankel. So there will be a white line of Frankel, which is sclerosed line. Then you will see this spur, and what you see is pencil like thin cortex, very thinning of the cortex is seen, right? So this is called Pelton spur, and you see the white line of Frankel and the epiphyseal ring. So they will see epiphyseal ring. So these are all the characters of the vitamin C. So ring like epiphysis. So the epiphysis becomes ring like epiphysis. Then you see there is a white line of Frankel. Then there is extension of this, the Pelton spur, and the cortex is very thinned out. Here what you see is the cupping, fraying and splaying, and you see the deformities in case of your rickets. So that is about the rickets, and that is about your scurvy. Both are again very, very important. They might be asking you in the upcoming exam. And now there is no end of orthopedics without the pediatric aspect. A very, very important question, that is your CTEV, that is congenital talipes equinovarus. So, and one more condition, that is your developmental dysplasia of hip, that is DDH. So here you see what is called as a Dennis Brown splint. So this can be asked as the image based question. So here you give for CTEV patients. And now this is called as your Pavlik harness. This is called your Pavlik harness, where it is used for treating of DDH for children who are less than 6 months, right? So this is DDH and this is CTEV. So what is CTEV? Where there is a defect in the foot. There is a lot of pathology which is present in the foot and ankle, which will result in what is called as the club foot. And how do you treat it? You first always treat it with the Ponseti method. The Ponseti method is the one which is used, that is by your serial casing. So you do the serial casing. When you do as early as possible, you can also do on the first day of the newborn, that is the serial casing which is done, and usually it takes 6 weeks for complete recovery into the normal foot. And after complete recovery, you maintain it, and for that maintaining you use this DB splint. So this is 24 hours for first 3 to 6 months, then you shift it to 12 hours, that is day and night, right? And then you put them into CTEV shoes once they start walking, right? So this is the plan of CTEV. Then what are the deformities which you see in CTEV? You will remember that as cave, that is cavus, adduction, varus and equinus, right? So these are all the deformities which you see, and this is the order of correction. So again, how do you correct them? Order of correction is also cave. First you have to always correct the cavus, then you have to correct the adduction, then varus, and finally you will do the equinus correction, right? So equinus correction, how you do? You attempt the 𝐸𝐂𝐴𝐶𝐿 method. So you will create a slit in the 𝐸𝐴𝐶𝐿 as a final correction, where the equinus is corrected, and put the limb, that the ankle, into flexion, right? So this is about the CTEV. And now coming to the DDH. DDH, we already know that there are certain risk factors for the patients. So whenever it is the female, the firstborn, the breech position, oligohydramnios, so these are all certain risk factors which you see in case of your DDH, right? So what is more important is the breech position. So the breech position, whenever you see the female firstborn with the breech position, and if there is a history of any ligament laxity in the family, you will always screen the newborns with the two important tests, that is Otterloni and Barlow's, right? So these two are the important tests which we have already discussed. And once you see there is some abnormality in this, then you go for ultrasound screening. So whenever, if the patient is less than 6 months, you go for Pavlik harness. Then if it is more than 6 months, you have to go for open reduction. So you go for open reduction, and more than 6 months. So first you will always try for closed reduction, and then if it is not possible, you go for open reduction. But when the patient enters the teenage or more than 10 or 12 years, you have to always go for THR or the replacement. In between you can always go for what is called as osteotomy, right? So osteotomy, if the patient is walking age, that is up to 3 years, like somewhere around 2 years to 12 years, you can always try the osteotomy. There are two types of osteotomy. You can go for femur osteotomy or the pelvic osteotomy, right? So there are certain pelvic osteotomy, the Salters, the Pembertons. So these are all the names. Chiaris, not going into detail. And femur, you will go for varus derotation osteotomy, right? So these are the, so if it is less than 6 months, you go for Pavlik harness. More than 6 months, you go for closed reduction. And if it is somewhere around 1 year, you have to go for open reduction. And if it is 2 years, you go for femur osteotomy. More than 7 years, you go for acetabulum, that is the pelvic osteotomy. And if it is in teenage, that is 13 years, you go for THR. So based upon the age, you will decide the treatment for DDH. So that is how you have to treat it. So nothing to worry. Usually in the pediatric orthopedics, now they are asking about the imaged way. So if they show you this particular image, and where it is usually seen, it is seen in case of your CTV, that is, this is the DB splint. And what is this? This is your Pavlik harness. And one more thing, what you have to remember in pediatric orthopedics is your SCFE. What is SCFE? Slipped capital femoral epiphysis, where you see mostly you will get this question with the male patient who is obese and with some endocrinal abnormality such as diabetes or some growth hormone abnormalities, and this patient comes with the pain in the hip with the radiation into the knee. So this is how usually they present with skiffy. And once you see the X-ray, you will see that there is some abnormality in the epiphysis. It is slightly subluxated, right? So this subluxation of the epiphysis is called skiffy. And the one important thing is the Trethoven's sign. The Trethoven's sign is the line which you extend up to the epiphysis, and if you're able to cut the epiphysis, it is normal. If you're not able to cut the epiphysis, it is abnormal. That is Trethoven's positive for skiffy. So this completes the pediatric orthopedics. Mainly they concentrate on DDH and CTEV, then skiffy, and one more, avascular necrosis of the femoral head, which is called as the Perthes disease. So avascular necrosis of femoral head, which is usually seen in 4 to 8 years, which is called as your Perthes disease. So this is the Perthes disease. So these are the 4 important conditions which you have to remember in case of your pediatric orthopedics, right? And then finally we see this important triad. What is usually seen here? You can see that there is a posterior hairline, right? And there is a neck, that short neck with webbing, and there will be decreased cervical movement. This is all because of the fusion of the vertebra. This is called the Klippel-Feil syndrome. This is called the Klippel-Feil syndrome, where you see the posterior hairline with the short neck or webbing of the neck and with decreased cervical movements. This is because of the fusion. There is loss of this fragmentation of the cervical vertebrae, and then this is result in what is called the Klippel-Feil syndrome. This is the Klippel-Feil syndrome. Similarly, you have what is called as Springel's shoulder. So what is Springel's shoulder? Springel's shoulder is now there is an absence of descent of the scapula. So the scapula should actually descend from above to the position it should be. So whenever there is absence of this descent of the scapula, you will see the high scapula, which is very short and hypoplastic. So it is hypoplastic and short, and the shoulder movements are decreased. So this is the Springel's shoulder, and this is the Klippel-Feil syndrome. And you have the last one, the clinocranial dysplasia, where you see aplastic or hypoplastic clavicles. So aplastic or hypoplastic clavicle. So see, these are certain congenital anomalies, the clinocranial syndrome, the Klippel-Feil syndrome, and the Springel shoulder. And one more is the radioulnar synostosis. This been asked in FMGE 2021 or 22 somewhere. So this is the loss of movement. So there is a loss of movement, that is supination and pronation is lost. So this is nothing but your radioulnar synostosis, right? So this is the, so here what happens is between the radius and ulnar there is a bone which is formed which does not allow the movement. So here during the supination and pronation, the radius moves along over the ulna, right? So here because of this there is a loss of movements of the calcification of the interosseous membrane. So this is called the radioulnar synostosis. So these are the certain congenital conditions which you come across in orthopedics, which you have to remember in the exam point of view, right? And I hope we have completed the most of the portion regarding your preparation. Hope I have completed almost all the one-liners from the orthopedics. This helps you in your preparation, and I hope you have all followed and understood. If you have any queries, you can keep asking in the comments, or you can directly contact us. So this has been the upcoming schedule. We have been planning up to 15th January for all the 19 subjects for the same timing, 6 to 8. And I hope this makes you all will make this the your prime part in the preparation of the upcoming FMGE exam, and wish you all the best, and hope you all do well, and do meet us in the recall session with smiling faces. Thank you. Good night. Bye.